There are biological processes so fundamental to human life that they have been occurring in the bodies of half the world's population for all of recorded history. Yet they remain, for a remarkable proportion of the people who experience them and the people who live alongside them, surprisingly poorly understood at the level of mechanism. The menstrual cycle is one of those processes. It is not simply a monthly event that happens to women of reproductive age. It is one of the most sophisticated examples of hormonal orchestration in human biology, a precisely timed sequence of molecular events involving the brain, the pituitary gland, the ovaries, and the uterus, each structure communicating with the others through hormonal signals that must arrive in the right concentration at the right time in the right sequence to produce the outcome. The cycle is designed to achieve. Today, from the perspective of reproductive medicine and endocrinology, we are going to explain the menstrual cycle in the full scientific depth that it deserves, not in the simplified terms that most people received in a brief educational session years ago, but in the vivid mechanistic detail that reveals why this cycle is so finely tuned, what goes wrong when it is disrupted, and what the cycle's hormonal fluctuations mean for the health, energy, mood, and physical experience of the woman living through it. This video is for everyone who wants to understand this fundamental biological process. Whether you experience the cycle yourself, are a partner or family member seeking to understand what someone close to you experiences, are a healthcare provider who wants to communicate this information more clearly, or are simply curious about one of the most remarkable examples of biological coordination in the human body. Let us begin with the purpose of the cycle, because understanding what the menstrual cycle is designed to accomplish is the context that makes every individual phase comprehensible. The menstrual cycle is the monthly preparation of the female reproductive system for the possibility of pregnancy. Each cycle, the ovaries develop and release a mature egg, a process called ovulation, while the uterus simultaneously prepares a nutritionally rich vascularized lining capable of receiving and sustaining a fertilized egg. If fertilization and implantation occur, the cycle is suspended for the duration of pregnancy. If they do not, the uterine lining is shed, the menstrual period, and the cycle begins again. This preparation and renewal process is governed by a hormonal communication network called the hypothalamic-pituitary-ovarian axis, a cascade of signals that links the brain to the reproductive organs through a precisely regulated feedback system. Understanding this axis is the key to understanding everything that follows. The hypothalamus, a small but extraordinarily important region at the base of the brain, produces a hormone called gonadotropin-releasing hormone, or GnRH, in a pulsatile fashion, releasing brief pulses of GnRH into the portal blood vessels connecting it to the pituitary gland. The frequency and amplitude of these pulses change across the menstrual cycle in ways that determine which pituitary hormones are released and in what quantities. The pituitary gland, a pea-sized endocrine gland at the base of the brain, responds to GnRH by producing two critical hormones, follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. These two hormones travel through the bloodstream to the ovaries, where they orchestrate the development of ovarian follicles and the production of the ovarian hormones, estrogen and progesterone, that act on the uterus, the cervix, and multiple other tissues throughout the body. The ovaries respond to FSH and LH by producing estrogen and progesterone in quantities that change dramatically across the cycle, and these ovarian hormones feed back to the hypothalamus and pituitary, either suppressing or stimulating further hormone production depending on their concentration and the phase of the cycle. This feedback loop, positive in some phases, negative in others, is the biological clock of the menstrual cycle, the mechanism by which the cycle self-regulates its own timing and progression. A typical menstrual cycle lasts approximately 28 days, though the normal range extends from 21 to 35 days, and variation within this range is entirely physiologically normal. The cycle is divided into 4 phases: menstruation, the follicular phase, ovulation, and the luteal phase. Each phase is defined by a specific hormonal environment, specific changes in the ovary and uterus, and specific physiological experiences that women may recognize in their own bodies. The cycle begins with menstruation, the shedding of the uterine lining that occurs when pregnancy has not been established in the previous cycle. The trigger for menstruation is the withdrawal of progesterone, the hormone that maintained the uterine lining throughout the second half of the previous cycle. As the corpus luteum, the structure that produced progesterone, degenerates. Without progesterone support, the endometrium, the uterine lining, loses its structural integrity and begins to shed in a process that involves vasoconstriction, ischemia of the superficial endometrial layers, and the release of prostaglandins that trigger the uterine contractions experienced as menstrual cramps. Menstruation typically lasts 3 to 7 days, during which the body sheds approximately 30 to 80 milliliters of blood and tissue, the shed endometrium along with the blood from the vessels that supplied it. The iron content of this shed blood is the primary reason that women of reproductive age have higher iron requirements than men, and it is one of the reasons that iron deficiency is significantly more common in women. The follicular phase encompasses both menstruation and the days that follow it, extending from day 1 of the cycle to ovulation, typically day 14 in a 28-day cycle, though this timing varies considerably between women and between cycles in the same woman. During the follicular phase, rising FSH stimulates a group of ovarian follicles, small fluid-filled sacs each containing an immature egg, to begin developing. Each follicle grows, acquiring layers of granulosa cells that produce estrogen, and the estrogen produced by the developing follicles rises progressively as the follicular phase advances. The follicles recruited in any given cycle number approximately 5 to 30, but typically only one, called the dominant follicle, matures fully and proceeds to ovulation. The selection of the dominant follicle occurs through a competitive process in which the most developmentally advanced follicle produces the most estrogen, which suppresses FSH through negative feedback, depriving the other follicles of the FSH support they need to continue developing. The dominant follicle, already more sensitive to FSH, continues to grow while its competitors undergo atresia, the programmed degeneration of the non-selected follicles. As the dominant follicle grows to approximately 18 to 22 millimeters in diameter, a size visible on ultrasound, it produces increasing amounts of estrogen, and the rising estrogen begins to act on the uterus, rebuilding the endometrium that was shed during menstruation. The endometrium grows from a thin post-menstrual baseline of approximately 2 to 4 millimeters to a triple line pattern of 8 to 13 millimeters under estrogen's proliferative influence. Estrogen also acts on the cervical mucus, transforming it from the thick, scanty discharge of the early follicular phase to the clear, stretchy, egg-white quality mucus of the late follicular phase that facilitates the passage of sperm. The late follicular phase is characterized by the continuous rise of estrogen, and here the feedback system makes one of its most elegant reversals. Throughout most of the follicular phase, rising estrogen suppresses LH and FSH through negative feedback. But when estrogen rises above a critical threshold and remains elevated for at least 36 to 48 hours, the feedback switches from negative to positive. This positive feedback effect of high estrogen on the pituitary triggers a sudden dramatic surge in LH, the LH surge, that is the signal that initiates ovulation. The LH surge, a rapid, massive increase in LH concentration over approximately 16 to 24 hours, triggers the final maturation of the egg, the rupture of the dominant follicle wall, and the release of the mature egg into the fallopian tube. Ovulation occurs approximately 36 to 40 hours after the onset of the LH surge, and the timing is precise enough that fertility clinics use LH surge detection to time fertility procedures. The moment of ovulation is the brief window of the cycle during which fertilization is possible. The mature egg, now called an oocyte, survives for only 12 to 24 hours after release if it is not fertilized. Sperm can survive in the female reproductive tract for up to 5 days, meaning that the fertile window extends from approximately 5 days before ovulation to 1 day after. Understanding this window is the foundation of fertility awareness methods of family planning. Before we continue to the luteal phase, here is a pause for you. The hormonal story we have been describing, the precise orchestration of GnRH, FSH, LH, estrogen, and progesterone, is one of the most sophisticated biological systems in the human body. Have you ever had this explained to you at this level of detail before? Drop a comment below right now. Tell us what you wish you had known earlier about how this cycle actually works. We read every comment, and this is one of the topics our community most values the chance to understand fully. Following ovulation, the follicular phase ends and the luteal phase begins, named for the corpus luteum, the remarkable structure that forms from the remnants of the ruptured dominant follicle after the egg has been released. The corpus luteum, Latin for yellow body, a name that reflects the lipid-rich cells it contains, begins producing progesterone within hours of ovulation, and progesterone production rises rapidly to reach a peak at approximately 7 days post-ovulation. This progesterone surge transforms the endometrium from its proliferative state into the secretory state, a richly vascularized, glycogen-rich, immunologically tolerant environment specifically prepared to receive and sustain a fertilized egg. The corpus luteum maintains its progesterone production for approximately 12 to 16 days, a period called the luteal phase, after which it degenerates if pregnancy has not occurred. If a fertilized egg implants successfully, it produces human chorionic gonadotropin, HCG, which signals the corpus luteum to continue progesterone production rather than degenerating, sustaining the pregnancy until the placenta can take over that function. If no implantation occurs, the corpus luteum degenerates, progesterone and estrogen fall precipitously, and the endometrium begins the process that will become menstruation. The cycle resets. The hormonal fluctuations of the menstrual cycle do not affect only the reproductive organs. Estrogen and progesterone have receptors throughout the body, in the brain, the cardiovascular system, the bones, the immune system, the skin, the gut, and the pain processing pathways. The follicular phase, characterized by rising estrogen, is associated for many women with increasing energy, improved mood, enhanced cognitive performance, and a heightened sense of physical and social engagement, reflecting estrogen's effects on serotonin and dopamine signaling in the brain. The luteal phase, characterized by rising and then falling progesterone, is associated with the premenstrual symptoms that affect a substantial proportion of women. The neurological mechanism involves progesterone's metabolite allopregnanolone, a compound that modulates GABA receptors in the brain in ways that in some women produce paradoxical anxiety, irritability, and mood disruption. The sensitivity to allopregnanolone's GABA modulating effects appears to vary between individuals and may be influenced by genetic variation in GABA receptor subunit composition and nutritional factors including magnesium status, which modulates GABA receptor activity and is commonly deficient in women with severe premenstrual symptoms. Premenstrual dysphoric disorder, PMDD, the severe form of premenstrual syndrome that significantly impairs daily function, affects 3 to 8% of women of reproductive age. Common menstrual cycle disruptions deserve specific acknowledgement. Anovulatory cycles, cycles in which no ovulation occurs, are more common than most people realize, particularly in the perimenopausal transition and during periods of significant physical stress. Polycystic ovary syndrome, PCOS, is the most common endocrine disorder affecting women of reproductive age, characterized by anovulation, elevated androgen levels, and the polycystic ovarian morphology visible on ultrasound. The hormonal mechanism involves disruption of the normal LH to FSH ratio. LH is characteristically elevated relative to FSH, which promotes androgen production rather than the estrogen production that normally triggers the LH surge and ovulation. PCOS is associated with insulin resistance, which directly stimulates ovarian androgen production, connecting this reproductive endocrine disorder directly to the metabolic health themes we have discussed throughout this channel. Hypothalamic amenorrhea, the cessation of menstruation due to disruption of GnRH pulsatility, occurs when the hypothalamus perceives insufficient energy availability and reduces reproductive function as a physiological conservation measure. The hypothalamus, sensing through leptin levels and other energy availability signals that the body's resources are insufficient to support a pregnancy, reduces GnRH pulse frequency sufficiently to impair FSH and LH production, interrupting the entire hormonal cascade. The menstrual cycle changes meaningfully across the reproductive lifespan, and the perimenopausal transition deserves specific discussion. Perimenopause, the transition leading to menopause, typically begins in the mid to late 40s and is characterized by increasing cycle irregularity as the ovarian reserve diminishes. The biological mechanism involves a progressive decline in the quantity and quality of ovarian follicles, which produces less robust estrogen responses to FSH stimulation and less reliable LH surge triggering. FSH levels rise during perimenopause. The pituitary responds to declining ovarian estrogen output by producing more FSH, and a consistently elevated FSH level is one of the hormonal markers used to assess ovarian reserve. Menopause itself, defined as 12 consecutive months without a menstrual period, occurs at an average age of approximately 51 in the United States and marks the functional end of the hypothalamic pituitary ovarian cycle. The practical tools available for tracking and understanding the cycle have expanded dramatically in the past decade. Basal body temperature tracking, the measurement of resting body temperature immediately upon waking, captures the progesterone-mediated temperature rise of approximately 0.2 to 0.5 degrees Celsius that occurs after ovulation, confirming ovulation retrospectively. Urinary LH testing, ovulation predictor kits, detects the LH surge in urine, providing advance warning of approximately 16 to 24 hours before ovulation. Cervical mucus observation captures the estrogen-driven changes in mucus quality that signal peak fertility, the transition from thick, opaque discharge to the clear, stretchy, abundant mucus of the late follicular phase. These three methods, temperature, LH testing, and cervical mucus, are the best validated tools for cycle tracking, individually and in combination. The dietary and lifestyle factors that support cycle regularity and hormonal balance connect directly to the broader nutritional themes we have developed throughout this channel. Adequate caloric intake and appropriate body weight are foundational requirements for regular ovulation. Hypothalamic amenorrhea on one end, and excess adipose tissue disrupting the estrogen balance on the other, both impair the HPO axis. Iron adequacy is essential for women with regular menstrual cycles who lose iron with each period. Magnesium, which modulates GABA receptor activity and reduces prostaglandin-mediated inflammation, has documented efficacy for premenstrual symptoms at doses of 200 to 400 milligrams per day. Omega-3 fatty acids from fatty fish, walnuts, and flaxseed reduce the prostaglandin-mediated uterine contractions that cause menstrual cramps by shifting the prostaglandin balance toward less inflammatory eicosanoid metabolites. There is a dimension of the menstrual cycle that science has increasingly recognized over the past 2 decades, and that deserves explicit discussion in any complete account of this biological system, which is the profound connection between the cycle's hormonal environment and the broader physiological experience of the woman living through it. The pre-ovulatory estrogen surge of the late follicular phase does not simply prepare the uterus and cervix for potential fertilization. It acts throughout the body in ways that produce measurable changes in pain sensitivity, immune function, cardiovascular reactivity, sleep architecture, and cognitive performance. Studies using neuroimaging have documented that estrogen modulates the activity of the prefrontal cortex, the region of the brain involved in executive function, emotional regulation, and social cognition, in ways consistent with the heightened social engagement and verbal fluency that many women report at the peak of their follicular phase. The skin's collagen production is supported by estrogen, which is why many women notice improved skin texture and luminosity in the days before ovulation compared to the late luteal phase. The post-ovulatory progesterone rise of the luteal phase produces its own suite of systemic effects. Progesterone is thermogenic, raising the basal body temperature by approximately 0.2 to 0.5 degrees Celsius, and mildly sedating through its GABA-modulating metabolites, which may explain the increased fatigue and reduced drive for social engagement that many women experience in the second half of the cycle. Progesterone also promotes fluid retention by antagonizing aldosterone, producing the bloating and breast tenderness that are among the most commonly reported premenstrual symptoms and that reflect a real hormonally driven fluid shift, rather than a subjective complaint. The cardiovascular system shows measurable cyclical variation under hormonal influence. Estrogen promotes endothelial nitric oxide production, the same mechanism we discussed in our blood pressure and exercise videos, producing a modest vasodilatory effect that slightly lowers blood pressure in the follicular phase compared to the luteal phase. Heart rate variability, the metric we discussed as a marker of autonomic nervous system health, shows follicular phase predominance of parasympathetic activity that shifts toward relatively greater sympathetic tone in the luteal phase, producing the cardiovascular variability that has been documented in multiple studies of women across the menstrual cycle. These cyclical physiological changes are not pathological. They are the normal expression of the hormonal biology we have described, the body's measurable response to the hormonal environment of each phase. Understanding them as normal, predictable, and hormonally explicable rather than as mysterious or irrational is one of the most practically valuable outcomes of the deeper understanding this video aims to provide. The connection between the menstrual cycle and bone health is one that most women are not taught, but that has significant long-term implications. Estrogen is the primary defender of bone density in women. It suppresses the activity of osteoclasts, the cells that break down bone, and supports the activity of osteoblasts, the cells that build bone. The consistent, cyclical estrogen exposure of regular menstrual cycles provides ongoing protection against bone resorption that accumulates as a meaningful bone density advantage over the reproductive years. Women who experience prolonged amenorrhea, whether from hypothalamic suppression due to undereating, from PCOS with chronic anovulation and low progesterone, or from other causes, lose this cyclical estrogen protection and develop reduced bone density at rates that approximate those seen after menopause when estrogen levels decline permanently. This is why the restoration of menstrual regularity is a medical priority in young women with hypothalamic amenorrhea, not primarily as a fertility concern, but as a bone health concern that has consequences decades in the future. The immune system's interaction with the menstrual cycle hormones is an active area of research with important clinical implications. Estrogen is broadly immunostimulatory. It enhances antibody production, promotes T-cell activity, and upregulates inflammatory cytokine production, while progesterone is immunomodulatory, shifting the immune environment toward tolerance rather than reactivity. This explains the observation that autoimmune conditions, which disproportionately affect women, often fluctuate in their symptoms across the menstrual cycle, with many women reporting worsening of rheumatoid arthritis, lupus, or multiple sclerosis symptoms in the premenstrual phase when the immunomodulatory progesterone effect diminishes and estrogen withdrawal removes its immunostimulatory co-attribution. The relationship between sex hormones and immune function is one of the most important and most underappreciated dimensions of women's health medicine. For women who use hormonal contraception, oral contraceptive pills, hormonal IUDs, implants, injections, or patches, the cycle described in this video is suspended. Hormonal contraceptives work by providing exogenous synthetic estrogen and progestins in patterns that suppress the hypothalamic pituitary ovarian axis, preventing the follicular development, LH surge, and ovulation that the natural cycle produces. The bleeding that occurs during the placebo week of combined oral contraceptive pills is not a natural menstrual period. It is a withdrawal bleed produced by the withdrawal of the synthetic hormones, and it does not reflect the natural hormonal architecture we have described. This distinction matters for understanding one's own physiology. The cycle that occurs on hormonal contraception is fundamentally different from the natural cycle, and understanding that difference allows women using contraception to make more informed decisions about their contraceptive choices and their expectations for how their body will feel and function. The natural menstrual cycle, with all its hormonal variability, is, for the women who experience it, one of the most information-rich biological signals the body produces. It communicates the health of the HPO axis. It reflects the metabolic, nutritional, and psychological state of the body at any given time. It produces experiences of energy and depletion, clarity and difficulty, that are not random but are the predictable expressions of a hormonal environment that varies in a characteristic, understandable pattern every month. To understand this cycle, truly understand it at the level of mechanism rather than merely outcome, is to gain access to a form of self-knowledge that most women have been denied by educational systems and medical traditions that treated the menstrual cycle as a reproductive footnote rather than as the sophisticated health signal it actually is. The goal of this video has been to provide that understanding, clearly, accurately, and with the respect that this fundamental biological process has always deserved. The menstrual cycle is a vital sign, a measurable, trackable indicator of health status rather than merely a reproductive event. The American College of Obstetricians and Gynecologists formally recognized menstrual cycle characteristics as a fifth vital sign, alongside blood pressure, heart rate, respiratory rate, and temperature, in 2015, reflecting the clinical consensus that the cycle's regularity and character provide meaningful information about the overall health of the women who experience it. This recognition transforms the way the cycle should be thought about, not as a monthly inconvenience to be managed and minimized, but as a biological report card that the body continuously generates about its own hormonal and metabolic function. The woman who understands what her cycle is telling her, who can recognize the hormonal underpinning of her energy, mood, and physical experience at each phase, is equipped with a form of health intelligence that is genuinely powerful. Irregular cycles, absent cycles, very heavy or very painful periods, or cycles that change substantially in their character over time, are all reasons to seek medical evaluation, not because disruption is always pathological, but because the cycle provides diagnostic information about hormonal and metabolic health that is genuinely valuable and that informed evaluation can act upon. Endometriosis, the growth of endometrial-like tissue outside the uterus, affects approximately 10% of women of reproductive age and is one of the most common causes of severe dysmenorrhea and altered cycle character that warrants specific evaluation and treatment. If this video gave you a scientific understanding of the menstrual cycle that you have never had before, the mechanisms, the hormones, the feedback loops, the connections to broader health, please support this channel. Hit the like button right now, subscribe so you never miss a video, and leave a comment below. Tell us what part of this biological story you found most surprising, or what you wish you had known earlier. We read every comment, and this is one of the conversations that matters most. Thank you for watching. We will see you in the next one.